So before we get started, we have a lunch sponsor today. John Broadus, Vice President of Luna Health, is going to spend a few moments talking about his company. So welcome, John.
Good afternoon, everybody. Thank you so much for being here. And the HIMSS Austin chapter has been fantastic for us to work with. In fact, we just started working with the HIMSS chapter just this past, last month. It was our first time being a part of the organization. And so we're excited to be a part of it. My name is John Broadus. I'm with Luna Data Solutions. We're a brand new friend. And hopefully we'll be a longtime friend of HIMSS Austin's chapter. There have been some really good folks here. I want to make mention of Shannon Vogel has been instrumental in helping us to get on board, and Emma Cartmel has been fantastic as well. So I just want to give a little shout out to those two individuals for helping us to become acquainted with the chapter and to be more affiliated with some of the things you guys are doing. So just real brief, if you'll humor me for a moment or two, Luna Data Solutions, led by our founder and CEO, Dana Jones, is one of the most respected full spectrum staffing and recruiting firms in Austin. We specialize in the placement of professionals locally here in Austin, as well as the great state of Texas, as well as the country. Luna Data is comprised really of four key practices, and those practices are Luna Government, which deals with a lot with government contracts and IT types of implementations and things of that nature. Luna Technology, which is software architects, engineers, developers, big data implementation specialists, and that sort of thing. Luna Creative and Marketing, kind of self-explanatory, but front-end folks, user interface, web design, content creation, and last but certainly not least, Luna Health Sciences, which is what I'm a part of, which spans healthcare roles, life sciences, biosciences, biotech, and that's the area that I want to be able to focus on here with the HIMSS chapter and in this Austin market. Our years of success stems from our unique ability to understand the challenges of our clients that our clients face, and by creating customized solutions that address those particular challenges in a timely fashion and on budget. So we are truly a recruiting firm, a headhunting firm, whatever you may want to call it, that really specializes in finding exceedingly outstanding talent. We've got over 16 years of experience, and we've established ourselves as a premier recruiting firm, not only here in Austin, but also abroad. We've got the financial strength and the flexibility and ability to deliver innovative solutions for our clients' staffing and talent recruitment challenges. Whether your company is here in Austin, in another city here in the state of Texas, or you've got a national footprint, we can deliver solutions in administrative, information technology, creative design, marketing, healthcare, biotech, science, life sciences, and other skilled areas of hiring. So I'm happy to meet with you all. You have my card. You have a couple of little trinkets, some writing tablets and things of that nature, and feel free to reach out to me if you have any hiring needs or any questions I can address. Thanks again for being here today, and have a great day.
Thank you very much. Thank you. And thanks for lunch. Other chapter sponsors in the audience, could you just raise your hand? Other sponsors do we have here? Great, and thank you so much for being sponsors of the chapter. You guys are the ones that give us the ability to have such great events and bring in such great speakers. So I also want to recognize very important volunteers on the board, and that's our board chapter members. So people that sit on our board. So going down the list, past President Lillian Prince in the back, and please stand up. She's already standing up, so. Advocacy, Chuck Durant. Not only Chuck is here. Communications Web, Don Deacon. There's Don. Membership, Kristen Norton. Secretary, Josh Berman. Is Josh here today? Okay. Social Events, Emma Cartmel. Emma's not here. Okay. Sponsorship, Shannon Vogel. Shannon. Treasurer Jake Bilch. Who's Jake? Joe's Jake. And I also like to announce we have a brand new board member who's our new student liaison. She's a student, and that's Megan Anderson right there in the back. All right, so before we get started, where's everybody from? So the vendor startup community, vendors or startup, okay. Consulting, academic, health systems, okay. Government, how about nonprofit? Okay. Any others that I might have missed? Say again? Others, okay. Big category. And students, of course. So who's hiring? Who's currently hiring right now in their organizations? Okay, great. And who is looking for employment? Okay, so let's do this as we've done before. Let's kind of meet. We can kind of mingle over in this corner if you'd like. And let's go right into our introduction. I'm very excited to introduce our speaker for this month. Dr. Vishwanath is a professor of data science and informatics at the Cockrell School of Engineering at the University of Texas. He received his PhD in engineering from Stanford University in 2003 and has been in the domain statistics analytics for 15 years. Dr. Vishwanath has over 150 referred research papers and has graduated 19 PhD students over the past 12 years as a professor. Dr. Vishwanath specializes in enabling high-precision prediction solutions and is the co-founder and president of Accordion Health. Please welcome Dr. Vishwanath.
Hello? Yes, there we go. All right, everybody. Now, I know this is lunchtime, so I want to keep it informal. Please ask me, interrupt me with questions. What I have is not meant to be a lecture style. I know I'm a professor. I tend to profess. But feel free to say, yeah, stop ranting, focus on, so please keep it bidirectional to the extent this interests you. So let me tell you my trajectory. As Doug mentioned, I did my PhD in 2003. I've been a professor here almost 13 years. This summer it'll be 13 years. And I initially did a lot of, doing my PhD, I didn't do healthcare. I actually did a lot of network and what is called OSI stack analytics. So those agencies that collect metadata, well, yes. Anyway, the analysis of network traffic to look for anomaly patterns, all of that, that was my initial start. I did a lot of consumer analytics. I spent 5 years working with the companies that we all integrate with, the Googles, the Facebooks, the Amazons, on the consumer side, and then I shifted to healthcare. And I took on healthcare because it interested me. Honestly, it got me excited. It got me thinking about the possibilities. I was tired of trying to sell you more stuff. I really wanted to see how I could help. That was the main reason, because in consumer, it's largely targeting you to figure out how to sell you more stuff. But also, because healthcare I found to be much, much harder in terms of analytics problems than the consumer space. The consumer guys, the Googles, the Amazons, the Facebooks, in my view, have it easy. I know you may say, what are you talking about? They spend billions of dollars on research. They mine petabytes of data. True. In consumer, at about 1 or 2 petabytes is when you're getting warm. 10 to the 15, right? 10 petabytes, 10 to the 16 is when I'm kind of happy. 10 to the 18 is when I'm getting really happy, right? But in healthcare, the problem is much, much smaller scale. I have less data. Even if I could have all the medical records, I may not get to petabyte scale, right? Yes, with some of the imaging data, I can get pretty high, but with claims, traditional clinical lab data, I'm talking about giga to terabytes of data, 10 to the 12, okay? Many orders of magnitude smaller. And what's more, in healthcare, what's challenging, what's interesting, what's exciting, is you want to predict early on. If a patient has 30 different events that have happened to them, predicting the 31st is very valuable, it's very important, but it's not as technically hard as if they've had 2 events and you're predicting the 3rd. Or because there's a whole bunch of records missing, The patient has been going in and out of the system, and all you can do is track them once or twice a year. And from that limited tracking, you want to be able to predict that something bad is going to happen. So healthcare has as much a big data problem as a little data problem, in that there's very little of it. For those who matter, in fact, what you have access to, and when you have access to it, the amount of churn, which is amount of in and out, the amount of gaps, the amount of up-coding or down-coding, or the case may be wrong coding, the amount of bias, the amount of what's called variance, is very high. And so the SNR, signal-to-noise ratio, which is what people talk about, the consumer guys have it great. Okay, the signal-to-noise ratio is great. You usually get on a website and go click, 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 and by the time you're done clicking through a whole bunch of websites, the hours you spend online, I have a ton of data about you. On the healthcare side, due to regulatory aspects, various other aspects, I don't have as much data about you, but when I have that data, it's very noisy. So there's a big challenge there, right? So I just want to speak to that. I want to tell you healthcare predictive analytics, when people say personalization, they say prediction, is a lot more challenging than consumer. So if somebody from, say, a Google were to come to you and say, I'm going to predict, I'm going to use Google's fantastic engine. How many of you have heard of TensorFlow? Anybody heard of TensorFlow? Google open sourced its deep learning, one of its deep learning engines called TensorFlow in November of last year. Very cool, very exciting. Problem is, it was designed for consumer. Okay? And for consumer, it's used to gobs of data. It's a data sink. It'll sink in data and then give you a measly prediction. Okay? In healthcare, you don't have that luxury, but also consumer analytics is not necessarily well suited to healthcare analytics. Healthcare, as James will tell you, everybody will tell you, has behavioral challenges, has multidimensional challenges that go beyond the buckets in which I can throw you in the consumer world. So you have to be conscious of the fact that healthcare is a much higher dimensional problem. All right, I'm done with my prelude, so I'm going to go into what are the issues. And these are conversations I've actually had. These are paraphrased. But you're all familiar with this, which is I have a black box approach. I give you a box, and it's going to give you a risk score. We're all familiar with that. It's going to risk stratify. It's going to population manage. It's going to do blah, blah, blah. All of that is good. I know I've been told a risk score of 3 is bad. Do you know why a risk score of 3 is bad? Do you know why 2.7 is not bad? Does anybody know that? I honestly, I'm a data scientist. I don't know. I don't know why 3 is bad and why 2.7 is not bad. I know 4 is worse than 3, but I don't know how much worse. How much worse is 4 than 3? Do you know? What I'm getting at is putting a number to your head is not exactly the job that data science should do. What it should be doing is saying, for you, Leanne, if I may call on Leanne, this is your trajectory. Okay? Things are looking good. This is when things may not look so good, and hopefully that never happens, but understanding your trajectory is more important than putting a number to your head, right? And so that's what has happened conventionally, and I won't speak to these, but I want to tell you what I believe historically we have done in healthcare that has not helped us. We have relied on the plan side and even on the increasingly on the risk-taking provider side on actuaries. And by the way, actuaries, I'm a statistician. I learned actuarial science as a student. Love actuaries. Actuaries have their place, have their value. But you know what actuaries do, which causes us problems? They conflate financial and medical risk. Actuaries are really risk classification engines. They're statistical engines designed for that. There's a depth of knowledge over decades created there. But meant to be financial models. They were meant to understand financial behavior. What we have learned over time, and done this the wrong way, unfortunately, is we've taken financial models and started applying them to medical behavior, saying this person is a high risk because the actuary tells me they're high risk. Financial and medical risks don't have to be the same. In fact, in many aspects of healthcare, they're not the same. What do I mean by that? Everybody in life goes from low to high medical risk. It's a fact of life. Can I be a little depressing for a moment? All of us are going to die. Right? So we are going to go through from low to high medical risk some point in our life. That does not mean that we have to go from low to high financial risk. But an actuarial model will conflate the two. It will give you a risk score That's a number. Is that a financial risk? Is that a medical risk? Well, actuaries are designed for financial risk. So they take that and apply to medical risk and give you something that mixes the two up, right? You need an understanding of medical risk, and you need to understand as that medical risk changes with time. Everybody's medical risk changes with time. You go from low to high. That's a fact of life. It may happen very gradually. It may happen very suddenly. Or it may happen, because as you know, in terms of chronic conditions, it may happen over a period of time, in some cases with jumps, right? You need to understand the financial risk associated with it. The financial risk, ideally, is always kept managed. People may go from low medical, low financial to high medical, high financial. But what should never happen, and this unfortunately happens in the healthcare system, is people who are low medical risk end up in high financial risk. It's the bad ER visits behavior. It is the diabetic who decides to pig out, right? The low medical risk but high financial risk category is the category that's immediate low-hanging fruit. That's where the maximizability lies. It does not lie in telling you what happens last month. That's valuable. History teaches a lot. But ultimately, based on history, we want to understand where you're headed, which is where the whole prediction aspect comes in. All right. So you want to be, on the financial side, a precision actuary. And I'm using the word precision actuary very carefully here. You want to focus on that 3 to 5% that drive behavior, right? Here's the amazing thing I've noticed when I've dealt with healthcare records. You could give me 10 million lives, and I can go around saying, I have 10 million lives in my data set. Sounds fantastic, right? 10 million lives in my data set. From that 10 million lives, I can remove 9.5 million and leave you with 500,000 lives, and you'll get the same utilization and cost values. It's because 3 to 5% drive 60 to 80%, 4/5 of the utilization patterns. So how does it matter? Congratulations, data analyst, you have 40 million lives. Well, of them less than 1 million matter. So the remaining 39 point whatever, just delete them, and you will still get the same utilization and cost patterns. So the challenge in healthcare is not how many lives I have. I mean, yes, from a money perspective, good for you. You have 40 million lives, you're going to get more money. I understand that. But from an analysis perspective, from a technical perspective, what really matters is the tail. Healthcare, unlike consumer, some network is like this, but consumer is not like this. Consumer behavior is very different in that in consumer, what you try to do is you take your data, you do what is called outlier detection and rejection. Anybody familiar with that? You take the data points and you reject outliers. You say this person is an outlier. And then you model the bulk. Okay? You cluster, you pre-process, you embed, you find a kernel. I don't know if you're familiar with all of this. You do all of that for the bulk, and then you say, yeah, those people are buying pattern anomalous. Okay? Those people are click-through anomalous. You've heard these terminologies. You say, they don't really matter because they're anomalies. You know, in healthcare, you have to do the reverse. You don't need to do anomaly detection and rejection. You need to do outlier identification and modeling. Because the bulk, 90%, never mattered. In fact, you need to take what is the norm and delete it. It's the norm that doesn't matter. Because the majority of people are not heavy utilizers. Make sense what I'm trying to say? So it's the opposite. The goal is actually the opposite. So building a precision actuary, actuaries are averaging institutes. What they do is they use statistical averages, they use moments to build a model. Yet I'm telling you, there's no averaging. Most people, the norm, the average, is good. This is called heavy tail, meaning the tail is driving the bulk of the behavior, right? Such a system is called a heavy tail system. When the tail drives behavior, and network also you see this, when the tail drives behavior, then you need to focus on the bulk. You need to focus on the middle, remove the middle, and focus on the tail, right? That's the difference in a precision actuary or a personalized medicine engine. It focuses on the few people that will make a big difference from a high risk or a rising risk perspective. So what's rising risk? Meaning you look okay today, but 6 months from now, they're going to be a big problem for you, right? Okay. So a lot of vendors, and this is just a joke, folks. It doesn't apply to any specific vendor. I think there are many good vendors out there. But there is a little bit of sales pitch going on. And telling who actually has something and doesn't have something is a very hard job. You have to go into the guts. So I don't claim I can do it. But what I can tell you is, nowadays, it sounds very commodity. You can just plug it on something and go with it. And this honestly gives us data scientists a bad name, because when anybody and everybody says predictive analytics, then it seems like what you do is commodity. Come on, I mean, anybody can do it. My neighbor does predictive analytics. The dog in the shed does predictive analytics. What's the big deal about you? And so at some point, the sales pitches have to die, and technology has to dominate. And I believe it will happen one day. So I have faith in that. So I want to, in one slide, summarize what I think is a good approach. I'm suggesting this as an approach. I'm not saying it's the approach. There are many other approaches. But I believe this is a good approach to analytics that ultimately will have an impact on healthcare. We are, from a cost, utilization, behavior, contracting, and ultimately national socio-political implications perspective, we are on the path where analytics is going to impact healthcare in a big way. We all know that. That's why we're here. That's why I'm here. That's why I got into it. So I believe this is an approach that is going to be impactful. Summarization is good, but ultimately start personalizing. It's good to know what a county looks like. It's good to know what a particular provider group looks like. All of that is valuable. But beyond summarizing, understand that 3 to 5% and what trajectory they're on. Understanding high risk is very important, right? So know who are the high risk ones, but go even deeper down. Understand where there's a change of risk. To use numbers, again, I don't believe your numbers. You're going from a risk score of 2 to 3, right? Both. You want to understand both. They're different, but you want to understand both. So very good question, by the way. When I say risk, I typically end up meaning full risk. I mean medical and financial risk, but you're right. Risk is actually a vector, meaning there's a multiple different types of risk, depending on institution. You want to understand each one of those risk types, depending on what's most important to you. So on the provider side, very much medical risk. If you're a full risk, medical and financial risk. And on the plan side, I would say, again, both. So as you know, providers and plans, and that's why I titled it this way, they're working closer and closer together. The line is blurring. And so whether it's medical, financial risk, operational risk, supply chain risk, understanding all of those risk patterns and not conflating them, not treating one as the other, is important. And doing so not just at high risk. Yes, this person has 10 tubes sticking out in the high risk. I get that. It's very important to be able to manage them very carefully. There's a lot of money involved. But doing that proactively, understanding that risk while you're looking fine today, and doing that predictively is where the word predictive analytics should really play. I should be able to predict non-obvious cases. If I can only predict obvious cases, there's still value there. I want to emphasize this value in predicting obvious cases. But predicting the non-obvious cases is where actionability is also high. So if I can do something to show you the non-obvious cases and the obvious cases, there's tremendous value there. One thing I want to say, and this is with all due respect to the entire healthcare ecosystem, what we tend to do typically is we spend a lot of time risk stratifying patients. We say that patient is high risk, that patient is low risk, that patient is medical, financial, otherwise. We need to understand how providers play into that. So that means not just when I say provider, I don't mean a physician, I don't mean physician by function, I don't mean admitting, operating, discharge. I mean the whole ecosystem around it. I mean the certified case managers, I mean the nurse practitioners, I mean all of those people who interact either directly or indirectly with this patient. Because the truth of the matter is that interaction, that provider's care patterns, that provider's choice of appropriateness, that provider's choice of route of care, that provider's choices impact that particular patient in ways that are way beyond what you think. To put it more bluntly, the good part, and a majority is good part, is providers making very unhealthy, very sick patients healthy. The bad part is prescription patterns, coding patterns, care choice patterns that can take an otherwise healthy patient and make them sick, right? And this may be also it very often is the patient's fault, right? But understanding how that patient interacts with provider or providers, as the case may be, that interaction is where a lot of the predictive analytics has to lie. You understand what I'm trying to get to? And by the way, one of my friends who I thought is a fantastic speaker just gave a recent talk, and he said something beautiful. I just want to quote him. I want to attribute to him. He said, very often it's not about finding the best doctor. It's about finding the right doctor. It's about finding the right, not just doctor, the right provider ecosystem for that particular patient. So there is, for patients that belong to one profile, a particular right ecosystem. For a patient belongs to a different profile, another particular good ecosystem. There's not a universally good across everybody. So personalizing that payer-provider interaction is immensely valuable, and we'll be heading that way very soon. All right. I don't know how I'm doing on time. When do I have to finish? Okay. Then I have to speed up. So analytics opportunities are many. I just want to show you a few. I do believe, I'm a very strong believer in quality and understanding quality. I know quality is extremely subjective and very hard to judge and a very challenging thing to do. But if we can do it in a way that incentivizes everybody without making them miserable, and I know what I'm talking about when I say miserable, we have to understand how to do so effectively, to do so in a manner that genuinely adds value ultimately to the patient. Plan revenue, provider revenue, and of course, ultimately adjudication. The many, many opportunities. I'll mainly be talking about quality in this talk, but I'm happy to talk about revenue, about PBM or medical claims adjudication sides as well. So when I get to quality, I'll talk about two sides of quality. One is the care management piece, the intervention piece, and the other is the contracting piece. The STAR measures, HEDIS measures, PQRS, MIPS. I don't know how many of you are living through MIPS right now, but that whole process. So and I don't know if this is no, it's not. Okay. This is the process that I personally have subscribed to. This process, and I'll give you an example of this, takes data and embeds it in the ambient dimension it belongs to. So what do I mean by that? We as humans can see 3D, right? We can see 3D. We like 3D. But we tend to process all our data in 2D. What do? We put it in a table. We're very used to 2D. We're used to tables. Excel was made for us, right? And then we process it. Your data may not belong to 2D. Okay? It may belong to 4D. You can't see it. That's a problem. You can see 4D. I can't see 4D. But it may belong to 4D. It may belong to 8D. And at that point, you don't even know what 8 dimensions are. So making it row by column may not be the best way to deal with the data. You may want to do it in a tensor fashion, which is row, column, 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 right? Multi-dimensions. And the reason is, when you flatten data, you may flatten features. Okay, I'll give you an example of that. When you take data sets, I'm talking about your claims, prescription, lab, specific data to that patient, socioeconomic, behavioral, and when you put it on one flat thing and say, these are all my features, you tend to lose the fact that some features may matter a lot more than others. And then you just weight them, you build a regression model, and that works, right? That's how we have done it typically. You want it to belong to the dimension it actually wasn't to begin with. And then in that embedding, you want to do everything from random forests, nearest neighbors, as well as your regression models. You can do high dimensional regression as well. And then you want to do something called boost them. You want them to all work together to give you the best model possible. All right. Now, one thing I want to point out, even though I have limited time, is this feedback process. You know what the best thing about prediction is? And I don't know why we don't do this enough in healthcare. They come true or not, right? If they come true, you predict it correctly. That means it needs feedback in the engine to improve the prediction for the next cycle, given that you got it right. But the sad thing about prediction is, and this is always true whether it's anything you're predicting, you're sometimes wrong. And we said, I cannot predict with 100% accuracy. I never can, right? Whenever you're wrong, or whenever something happens, like an intervention, which changed the state of the system, you want that to be fed back. And you want it to adapt as it is fed back. One thing we tend to do, and this is unfortunate, and we do it in other fields too, but I've seen this a little too much in healthcare, is we take a static model we built for last year and apply it repeatedly this year, right? Last year may be a good reflection of this year, so that's not a bad thing. But then, hopefully you're adapting this year. You're learning from that model. And as you learn, that feedback needs to inform the model. It needs to change how that model was to truly reflect the trends this year. And it needs to do that in as much real time as possible. And this doesn't have to happen on a minute or second time scale. This can happen on a daily, weekly, even monthly time scale. But as long as there's some adaptation, that's very important. All right. So, a quick example. Here are about 100 patients. Can everybody see the dots? I know they're tiny. 100 patients, they all had a procedure, knee replacement, and this is 4 months out. The dots here stand for different events that happened to them post-knee replacement. Some of them came back, had a readmission. That's a major dot. Okay? The color of the dot is type of event. Some of these tiny dots are just follow-ups. They're low expensive, very less expensive events. Okay? 100 patients, all with different events. You know, the classic question I ask, does anybody see a pattern here? No, right? Good. What did I do? I took all the data, I flattened it to 2 dimensions, put it as time and event, and asked you to predict. It's very hard to predict because the data doesn't belong to this dimension. These events lie in a higher dimensional space. And when you put them in high dimensions, you can start seeing patterns. That ability to see patterns across these different events, right, all differently colored, different spaced, differently timed, and to do so across time, to find causal paths. So let me talk about what causal paths are. Most of us, we think in a correlation mindset. Is this correlated with that? Correlation is a two-dimensional thing. It takes 2 factors and looks at if they're interdependent. But ultimately, we want to look at dependency that goes beyond 2 dimensions. Okay? It's not just correlations. It's higher order dependency. Unfortunately, in this world, most things are correlated. Right? How do I put it? I'm sure my shoe size has something to do with the way I run. It may be causal also, but there's a strong correlation. It may even have, as you know, most things in this world are correlated with cancer. Doesn't mean they cause cancer, but they're correlated. You see what I'm trying to say? Correlation is very different from causation. Causation is very, very hard to do. You don't want to just look at correlations, because that way you'll get what's called a dense graph. Everything will seem connected to everything. You want to understand higher order dependency. Are these dependent in 3 dimensions? Are they dependent in 4 dimensions? Are they dependent in 5 dimensions? And as you keep doing that, you will learn a lot more about what things are truly dependent and what else is just correlated. All right. So I can't do a demo. I was hoping I'd do a demo. Like I wanted to show you that you can look at an event and predict different events based on it. But I'm happy to show you the demo offline at some point. But what can you use this for? Let's say you could do dependency analysis. There is no PHI in any of my slides. They're all stock photos of people. But imagine you actually knew Joe, right? Joe is a 69-year-old man with COPD, and he has seasonal exacerbations, okay? Seasonal triggers. He also has hypertension. He doesn't always take his meds. You actually get his filling patterns, his lab data. And his risk score is a medium. If you did an actuarial analysis on the medical side, you would say it's a medium. All right. And you know his healthcare ecosystem. This is an actual trajectory. So what I'm showing you is not fake. This actually happened. Okay. This was 2014. This is 2015. Right. So this has already happened. 2016 is right here. So I'm just showing you what we knew about the patient, what we predicted. This dotted part is predicted. This is back last year. Predicted it. Okay. How difficult was this prediction? Not too hard. We knew seasonally he has COPD triggers. So predicting it, by the way, prediction was a lot of work. Don't get me wrong, because the data is still very noisy. There's a lot of holes in it. But we're able to fill it all up and predict that this patient is going to have a seasonal trigger again. It's going to have a major COPD event. What's interesting is not just the fact that you can predict this. It happened last year. It's going to happen again this year, right? You know, this is Austin, so this is February, March. I can imagine why he has COPD triggers, right? But associate costs are reasonably high, 800 PMPM. That's reasonably high. You can call him up 5 times to take his medications. He's just going to go, you again, hang up, right? Maybe a home visit could be much more effective. So the value here is not just that you can predict an event, but to understand what is most efficacious for this patient. What should I do about it? Huh? Yes. No, there could be many other triggers. In fact, seasonal only accounts to 20% of the entire explained variance.
So predicting this, how did you come to this conclusion with the data that you have? Because there might be other data that
Quite a bit. That will determine what your accuracy level is at the end of the day. So what you can do, and I'll show you the accuracy levels. The accuracy levels in the end, based on the data, accounts for less than 80%. If you're 20% of the time wrong, I would say don't do it. Just tell them you can't predict. I'll show you we predicted this. The accuracy level was high. And so when your measured accuracy is high on the data set itself is when you predict. Does that make sense? If the data set is so noisy that the measured accuracy is low, it's much better to go to them and say, sorry, can't predict. Because if I tell you this is going to happen and it doesn't happen, you lose confidence in me. Make sense what I'm trying to say? Yeah. So I'll show you what the accuracy levels are. What's more interesting is not just predicting the event. This is good. I'm not just telling a risk score. Risk score is whatever it is. I'm telling you this event is going to happen. And I'll tell you this. The event actually did happen. But what intervention is most valuable? This is what I would call an obvious case. It's very valuable. Understanding it's going to happen. But it's fairly obvious. Happened last year, going to happen again. What's interesting is Linda. No PHI, all fake names. Linda is a very conscientious 76-year-old. She has a family history of CVD. She has had some palpitations recently, but mostly asymptomatic. She's been doing great last year. Okay? Her risk score is actually low. When you look at a risk score, you'll see how low it is. But she's about to go into a major inpatient event. And she's going to cost 100K PMPM. That was 800 PMPM. She's going to cost $100,000. She's going to have a major stroke. Right? It's going to happen next year. The previous year, she was golden. She's an example of rising risk. The lab results are all below the threshold. It's just 6 months ago where they were to where they are today, it's rising. It's sort of, how do I explain it? We're very used to the dam water levels going beyond the red, right? It's when you're below the red and it's been raining the past 7 days, right? It is going to rise. The dam is going to break. But it hasn't hit the red level yet. Does it make sense? So that's where it is. It is the time series patterns in data. So whether it be, in this particular case, it's claims, labs, and clinical data, it is to look at where those patterns are going and how they've been rising. And they're predicted to go beyond to lead to this point. What's more, here's how collaborative filtering works. I know I have limited time, so I'm going to be quick about it. How many of you have heard of the Netflix prize? Okay, you're familiar with the Netflix prize. Can somebody tell me about it? What was the Netflix prize?
I think it was to improve their predictability by 10%.
Yep.
Smaller.
But what were they predicting?
The likelihood that of your movie preference.
Yes. Netflix prize just happened, they had multiple, but the $1 million prize just happened 7 years ago. And somebody won it. And the predictability went up much higher. The AURC 82%. Somebody achieved it. There was a team of people working late at night, winning it. You know what was the challenge? It was a little data challenge like this. You had watched and rated 2 movies. I had to predict the 3rd movie you'd like to watch. What was the problem there? Based on 2 movies, I'm supposed to predict the 3rd one? Doesn't sound easy, right? So you know what they did, how they went about winning this? They did something called collaborative filtering. They looked at other people who looked like you, okay, what they had watched. And based on that, started ultimately imputing and then predicting what you might want to watch. And saying there are so many personality types. There's so many common factors across people. And there's so many common factors across. So do you know where I'm going with this? We're doing collaborative filtering. We can extract cohorts from the data that resemble other patients who had a similar rising risk, except it already happened to them. And from that, give you a likelihood. I'm saying likelihood of stroke is high, right? I'm not telling you it's going to happen. Any prediction tools that tells you it's going to happen needs to eat its, needs to, because just like the weather, I can never tell you it's exactly going to happen. I'm going to give you a likelihood. The likelihood is high. That's when I'm going to tell you about it, right? Prediction accuracy is high. Yes. No. We are looking at the entire year to see how the changes happened over that period. Oh, in PM it looks flat. But in the clinical and other indicators, it doesn't have to be flat. Oh, I'd have to show you 4 dimensions, which is the hard part. True. No, there's beyond that. She collaboratively looks like a cohort of about 10 other patients who had a rise much up ahead. So it's not just her. It's beyond that. You see what I'm trying to say? It's not just her indicators. Oh, beyond that. Much more, even in terms of patterns of socioeconomic behavior, her care trajectory, what physicians they saw, that entire system matters. And all of that matters in predicting this. Yep. Fantastic. So I know I have limited time. I only have 5 minutes left. So I'm going to have to go through this. So why did I ever claim I could do this? It's because of measured accuracy. Okay? Here in green is the measured accuracy, while in gray is an actuarial model. All right? So on the same data set, so it's apples to apples. You use the same data set, and you use a logistical regression model in gray, and in green you use a high dimensional model. Now, if it is 75%, what it's trying to say is the net false positive, false negative rate is 25%. So 1/4 of the time you're raising either a false alarm or you're missing a genuine event. Does it make sense? That's what this means. The complement of this is the error rate. False positive, false negative. Z stands for AURC, area under the receiver operating curve. Okay? Now, when you see even 97% AURC, that means the net false positive, false negative rate is 3%. It's only when you have a high AURC or a low false positive, false negative rate should you be even calling to say that something is going to happen, or you should document this, you should look for this. Because if I'm wrong 25% of the time, that's when the whole false alarm fatigue happens. The alarm goes off, you keep going snooze, 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 because you're only used to taking so many false positives, after which you don't care, right? This is very important. This is where I think data scientists should take pride in what they do and not just say, oh, anybody can do it. You need to do it with high AURC. If as a data scientist you cannot do it with high AURC, you've got to be honest about it. Say, sorry, the AURC here is 80%, it's 20% false positive, false negatives. Please don't take what I'm presenting to you, because you will undergo fatigue. So this is where I want to focus. Yes? Overfitting is a huge problem. Overfitting is a huge problem. So this is measured accuracy. This is not overfitting. Overfitting will actually lower your accuracy. You cannot be 100% accurate, even in. So, and this often happens. It's statisticians are at fault, so I take blame for this. Here's what we do. Here's what we do. It frustrates me. But I've seen this happen so many times. People look at me at blank stares. Here's what they do. They take their data and they build a model on the entirety of the data. Okay? That's the problem. Then they take 1 or 2 test points, and then they say, I was right both times, so my accuracy is 100%. Okay? That is wrong. What needs to be done is you need to take your whole data set. You need to break it down into 2/3, 1/3 chunks. Ideally, 60-40, if you can get away with it. 60% needs to be training. 40% needs to be test. You need to test the hell out of it. If your accuracy number is 100%, you're doing something wrong. There's no way prediction can ever be 100%. You should know that, right? So if you're testing sufficient, if you're testing a lot of the time, and your tests come up 95% accurate, then you're doing a good job. Overfitting is a problem where you start explaining noise at the same time as you explain data. What I'm trying to say is, when you test too little and you spend most of your time modeling. So this is built on what is called an built on a holdout data set technique. It's a k-fold holdout data set. The way you do this is you take 3 years of data, you hide 6 months from yourself, you use 2.5 years. In this case, the ratio is about, it depends on how many events have happened, but in the 3/4, 1/4 range. You use 2 years or 2.5 years to build the model. Use 6 months to do all the tests. See, did you predict that 6 months correctly? And if you did, that's when you claim to have any measured accuracy. Did that answer your question? Perfect. Okay. So I was going to talk about quality prediction. I have almost no time.
I mean, we have 10 minutes for questions, but what does the group think about having just continue and maybe pepper in questions as we go? Want to do that? Okay.
Should I continue?
Yep.
So one of the things I've been spending a lot of time with collaborators, with my team on, is quality prediction, which is, I want to understand and I don't have a marker here, so I'm just going to point it, at a county level. I don't know if you can tell this is Austin, that is Dallas. At a county level, I want to be down to a zip code level. And at a plan/IPA level, across different, these are Part C, Part D measures, I'm sorry, the font is small. How are we doing on quality? And what is the inherent composition of the population, of the provider groups, of the contracting mechanisms in that county, in that zip code, that contribute to quality? There's different behaviors. Inner city San Antonio is quite a bit different from the suburbs. Austin is quite a bit different from central Austin to the suburbs and so on. There's a lot of socioeconomic, there's a lot of behavior, there's a lot of contracting, there's a lot of attitudes that matter in this entire process. All right, I'm just showing you snapshots. You want to also understand at a provider level, how is the coding patterns, how is the prescription patterns, how is utilization patterns driving quality. And ultimately, at a patient level, you want to understand in terms of whether it be HEDIS or otherwise. How is medication adherence? How is different clinical measures driving quality? Now, I would say this particular thing at a patient level, in understanding chase lists on patient utilization patterns, patient medication adherence, is actually a fair amount of work already done. However, on the provider side, I think there's a lot more work to be done to understand how providers influence that behavior. And by the way, just talking a little more about medication adherence. Medication adherence is a big deal. You want to target people with high actionability. As you know, CMS measures everything in PDC scores. It's largely on fills, not on actual taking of pills. And so you want to focus on those people who can get you to that 80% PDC score. As you know, 80% is the threshold. You may get to 79, too bad, so sad. It's not going to impact your score. Right? 81% is going to get you there. Causes for non-adherence. The causes are not always what you think. It could be any one of forgetfulness, optimism, financial, form factor. It's the pill form factor. Understanding how that impacts adherence is also a big deal. And ultimately, understanding what intervention strategy works best. Analytics is not just about telling you the trajectory of the patient. Analytics is about telling you how effective a particular intervention is. Yes? Yes. So actually intervention is very tricky. Thank you for bringing that up. Intervention won't come from claims, clinical, prescription, lab data. You will need to work with the case managers, with their CRM tools, with the people who are actually doing the on-the-ground intervention to understand what they're doing, document it, capture it, and then analyze it, which is already tricky. It's a lot of work already, right? But let's say you've done that analytics. You get into this whole chicken and egg problem. I intervened, so the person got better, but then the system is going to claim that would have never happened in the first place, so your prediction was wrong. How am I going to tell you that I predicted correctly and I told you the right intervention so it never happened, versus I predicted incorrectly and so it never happened in the first place? You see what the chicken and egg problem is? This is a huge problem. And by the way, we've had this from eons, right? This is not new to healthcare. This is true to all the people who work in the consumer space and every other space, which is, were you effective in changing the data system, or was it never going to change at all? For that, you need not just a ton of data at good SNR, so it's not always easy to do, but also you need to do this cohort extraction. You need to run many clinical trials in the back. We're all familiar with clinical trials. We're used to running them in reality, right? We set up people, we set up the control group, we set up the test group, and then we do the analysis on whether it was effective or not. You need to run virtual clinical trials in software, right? So you need to extract a cohort when intervention was not done. You need to extract a cohort where the intervention was done. You need to extract the pathways for each, and then show that one where the intervention was not done, the trajectory was different from where the intervention was done. It's tricky. It's very hard. Very non-trivial collaborative filtering. So think of it as virtual clinical trials that you're running constantly to understand from a data level what is impactful and what is not. Anyway, I hope I answered that question. So you can look at people by PDC score, understand how effective medication adherence is for them. And then one last thing I want to talk about in the very limited time I have is post-acute risk prediction. So one aspect that all of you are very familiar with is bundling, whether it be BPCI, CJR, various other bundling initiatives that now pay based on an entire 90-day episode. And so let me look at two patients. These are actual trajectories. This is a 90-day period. These are all patients that had the same acute event. Patient A was initially kept as an inpatient and then sent to a sniff and then discharged to home health. This is fine font. Ended up in home health, never got readmitted. This is the ideal trajectory, or a good trajectory to be on. Okay, not the ideal, a good. A bad trajectory is this one. Patient B was sent home and then got readmitted. Right? This is a bad trajectory. I've had people look at this and say, so what? Only about 5 to 10% of the patients got readmitted. Majority of them went home, stayed home. What's the big deal? No, it is a big deal, right? Because if that 5 to 10% that got readmitted just dinged you on a whole bunch of quality metrics, led to a huge increase in your costs, and those 5 to 10% of patients are not happy, right? So from a satisfaction, from a cost, from a quality perspective, this is very bad. Ideally, all of this should not be happening. Do you see all these upticks? Should all not be happening, right? How do you avoid these upticks? And how do you predict them up ahead that this particular patient, when sent to home health versus a sniff, is going to lead to bad outcomes? Again, predictive analytics, and you want to do it at high accuracy. So you can understand sniffs. Different sniffs are different. Things are extremely local, hyperlocal, and very facility dependent. One sniff is better at falling injuries. Some sniffs are better at diabetics. Some sniffs are better at CHF. So understanding what sniff does a great job in terms of their practice patterns and where you can, in a personalized manner, match that patient to the right sniff, to the right home health agency, or if they have the right ecosystem as an outpatient, is the optimization problem to be solved. And it has to be solved in a predictive fashion. So that's what I'm showing you here, which is you extract cohorts. Again, the same thing. It's collaborative filtering. You extract cohorts and understand for that particular patient, the cohort they belong to, what's going to be the cost, what's going to be the predicted all-cause readmission rates, and how can you choose the best outcomes for that patient for a given budget. With that note, I'm going to stop. Thank you for being a great audience. Happy to show you everything offline.